But medically ill patients that were prophylaxing for venous thromboembolism, there are other options. Enoxaparin or low molecular weight heparin, as you described, is one, although that's getting into shortage. Betrixaban and rivaroxaban have indications here. It might be opportunities. If we thought about that, how do we, at your institution or other places, how are people thinking about the medically ill population? How are we defining the medically ill population at risk? Is there a specific thing your organization's doing? I can certainly share some of the things we're thinking about.
Sure. I think what has kind of developed, I think, over the past maybe 3 years is that in the past, the medically ill population was one where, like, let's give prophylaxis to everybody who walks in the door. Yeah. And then it was like, well, maybe a lot of patients who don't need prophylaxis are getting it. So we've come back kind of full circle to looking at risk scales or scores. So for medical prophylaxis, there's a couple of the improved score or the PADOA score, but basically it's looking at things like respiratory diseases, COPD. Heart failure is a big one since it's such a large proportion of the hospitalized patients have heart failure. You can also look in terms of patients with rheumatologic diseases tend to be at high risk. Inflammatory bowel disorder patients tend to be at high risk. So there's many characteristics, and you can use a risk scale or score. Also, in general, critically ill patients tend to be at high risk. So, and again, those patients are getting a lot of procedures done as well. So you're concerned about using an anticoagulant in those type of patients that are getting procedures.
Yeah, I certainly think at our place we would probably say, similar to how you think about it, that we have a broad group of people that, you know, by their sheer nature being in the hospital, you're medically ill, obviously. You may be undergoing a procedure, you may have acute coronary syndrome, so you may have other reasons you're getting anticoagulated. But if you were there for heart failure, COPD, you have an advanced stage, you have other comorbidities, you're certainly going to be patients that...
Sepsis,
infections, yeah, ICU care that's not otherwise for coronary disease or at least anticoagulation disease. Those are patients that would certainly meet that, and then the data would say to us at least treating those patients both within that hospitalization but prolonged after that hospitalization may have a benefit. So there may be other value propositions here, but certainly the drop in the availability of heparins affecting us